All right. I'm going to test my audio, just make sure it's right working. Okay, I'm going to go test my audio because I don't want to do what happened last time and find out I did an entire article and it didn't record the voice. All right, it seems to be working now. All right, want to apologize for yesterday. I had it all planned out. We were going to have this lecture, quick review, and then we were going to have the exam today. It seems that people who had other decision power made their decisions, and thus things happened as they did. But we're going to make the best of what we have. Now, seeing as how at this moment I have a lecture that I have to give you guys, and I have an exam I have to give the other guys at exactly the same time. So I'm going to give this to you guys as a recording so that you guys can listen to it as you need to and pick up from there. So let's get things started. Part of this you may have had last week, and I hope you had the other part. Uh, but this is what we have scheduled for this week. So Sears is not a disease itself, it's a syndrome, meaning a cluster of signs indicate the body is in a state of systemic inflammation. I want you to think of this as a fire alarm going off. Inflammation is no longer local, such as a cut or even organ system like a pneumonia, but has spread systemically. Now, MODS, multiple organ dysfunction syndrome, is a consequence of the alarm being ignored or uncontrolled. So Sears is the trigger, MODS is the response or the consequence. So if the alarm is uncontrolled or ignored, you're going to have multiple organ systems failing because the inflammatory response damages the microcirculation and oxygen delivery, what we would in nursing call perfusion. Every organ has a minimal level of oxygen and nutrients that it requires to live. Certain organs have a higher level, other organs have a lower level, but all organs have a certain threshold of perfusion. So with this, looking at the triggers, why does SIRS start? Sepsis is generally the most common trigger. This is an infection, but SIRS can happen without infection. Things like trauma, burns, crush, injuries, surgeries, massive tissue damages, all of that releases inflammatory mediator chemistry. Um, Ischemia, necrosis, pancreatitis, myocardial infarction, bowel infarction, all of it, end result is there's certain kind of dead tissue. Dead tissue will trigger a cytokine storm, which causes other tissues to go into emergency response and or die. So any kind of necrosis, it can be something as small as a minor heart attack, or it can be something as major as gangrene. All of this will cause SIRS. Immune activation. Endotoxins from bacteria, autoimmune flare-ups will also trigger it. Perfusion deficits. So if we have some sort of shock, which we talked about last week, I should hope, reduces oxygen delivery, perfusion. So tissue hypoxia leads to an inflammatory cascade, which can lead to necrosis, which leads to cytokine storm, which leads to et cetera, et cetera, et cetera. So you see how the chain starts. So teaching point here is that SIRS is not a systemic inflammation. It is not just infection. It's very broad. And as we look at these things, I'm going to start talking. I want you to picture normal in the middle, and you have a left side and a right side. SIRS happens on if either we fall off at either side of normal. So back to cytokine release. Talking about the pathophysiology, of course, here. Cytokine release is interleukins, interferons, all of that flood the bloodstream. This leads to endothelial damage. Capillaries become leaky, leading to edema and poor perfusion. Basically, the cells that make up the blood vessels shrink, allowing plasma and other fluids to leak into the blood vessels, out of the blood vessels, and second spacing, leading to edema, etc., etc. And we end up with reduced volume in the bloodstream, hypovolemia. It also triggers blood clotting cascades, which causes microthrombi to form. Microthrombi are small blood clots that travel into the blood vessels until they hit something smaller than it is, and it will block that blood vessel. And everything downstream of that blockage will either become severely impaired or die, depending on where it's at. And keep in mind, microthrombi will form anywhere in the body. So it could be in the brain, could be in the lungs, it could be in the heart, causing strokes, heart attacks, or other tissue failures. One thing that's really fun and exciting about SEERS is something called hypermetabolism. The body goes into a hyper state. The body starts becoming overexcited. So it's going to start consuming oxygen and glucose at a very rapid pace. And normal perfusion is not going to be sufficient. And if the body cannot meet this increased perfusion, we are going to lead into organ failures. Now, generally, we talk about organ failures. Organ failures tend to follow a general pattern, and I'm going to say general because there are exceptions. But normally, the first one to crap out, to fail out, is the lungs, what we know as ARDS, acute respiratory distress syndrome. Following the lungs comes the kidneys, an acute kidney injury. Following that is liver, cholestasis, leading to an increase in bilirubin and damaged red blood cells, which then lead to et cetera, jaundice, the rest, which then lead to heart arrhythmias, hypotension, leading to central nervous systems failures, normally demonstrated as delirium and coma. I get a really bad analogy that's going to trigger in your head. So imagine your body's defense system is firefighters. So if in SEERS, you get an alarm and they have a fire somewhere in your house, the firefighters arrive in response to this alarm, and they're not exactly trained or competent or aware. So they just come in, running in, hell bent for leather, taking their fire hoses and turning the water on and just letting the water go. So everything is going to get damaged, including the area where the fire is, but including areas that the fire is not. So you're going to have damaged furniture, damaged walls, damaged everything, to the point where they can actually damage the walls to the point where the entire house comes crumbling down on top of you. So mods is where the end state where everything is starting to collapse. So what's the clinical criteria for SEERS? To diagnose SEERS, 2 or more of the following must be present. Temperatures above 38 or under 36 Celsius. So for those of you who are keeping score in the ballpark, anything above 100 degrees or anything under about 37-ish. Remember I was saying the left side and the right side. So if you're high, it'll be a trigger for SEERS. If it's low, it's a trigger for SEERS. Heart rate is going to be something greater than 90 beats per minute. Respiratory is going to be around 20 minutes, or partial atmospheric carbon dioxide under 30, greater than 32 mils. You can have a very high white blood count of 12,000 or a very low white blood count of 4,000. You would have a low count of 4,000 because the white blood cells have been exhausted by this point, so that's why you're running down. So why does all this matter? Temperature reflects a systemic inflammation or immune suppression. Heart rate, tachycardia, is compensation for hypoxia or fever. As far as respiratory values, we're looking at hyperventilation, and that equates out to metabolic stress. White blood count, we're either in overdrive, leukocytosis, or exhaustion, leukopenia. So, the clinical features of MODS. In respiratory, we have ARDS, refractory hypoxemia. We are going to need mechanical ventilation. Renals, we're looking at oliguria, rising creatinine. We're going to start ending up on dialysis and becoming dialysis dependent. Keep in mind, this is not something that happens right now and dies an hour later. This is something that happens and takes hours to days to weeks to reach its full crescendo. And back to the hepatic. I talked to you about the red blood cells being destroyed through the liver failure. We're also looking at hypotension, arrhythmias, and need for jaundice, coagulopathy, increased in bilirubin, leading to liver failures and hypovolemia. As far as cardiac, we have hypotension, arrhythmias, and need for vasopressors to help raise the blood pressure. Again, all of the hypotension is all again related to blood volume depletion. You're running low on fluid, because the vessels are leaking, so you don't have enough fluid in your vessels to maintain the blood flow. Neurologic, we're looking at confusion, delirium, and eventually coma. And I want you to remember, again, MODS is often sequential. Not always, but generally. Lungs first, the kidneys, liver, and so on. So you need to recognize the early signs. What is the management? Well, as always, we have to be the ones who recognize everything. So early recognition, how do we know this? We're going to be monitoring the vitals. We're going to be monitoring the labs. We're going to be looking for perfusion checks. There's a reason why we do all these things, everybody. Supportive care. We're going to start off with oxygen, easy stuff, fluids, vasopressors, mechanical ventilation as we progress. Remember, the first common trigger is sepsis. Doesn't have to be, but sepsis is generally one of the main triggers. So we're going to be looking at antibiotics. If we can find the source, we're going to remove the source, whether it be tissue debriding, draining an abscess, or even worse, amputation of a decreased gangrenous limb. Nutrition, enteral feedings. Generally, we're going to start with tube feeds and then progressing to TPN over time. We do not start with TPN. We will start generally with enteral feedings. Family support. Families are going to be terrified. They're watching things happen. They generally don't understand why. So our job is, of course, communication, referring in as many resources as we can, psychological, behavioral health, end-of-life discussions, whether it be palliative or hospice. So bottom line is that in MODS, nursing care is often about supporting the failing systems while the underlying cause is treated. If we can treat the underlying cause and keep the rest of the patient afloat, we have a chance. If we fail on either end, the patient will pass. I want you to remember these acronyms: SEERS, temperature, heart rate, respiratory rate, and white blood count. As far as MODS, organ failure, the standard order is lungs, kidney, liver, as in liver, heart, and neurologic. The other thing to remember is mnemonics, the triggers, mechanical trauma. You ever watch those TV shows where somebody gets trapped under something that fell on top of them, whether it be a falling file cabinet or a piece of the ceiling or a wall or a car, and the first thing people come do is pick up that car and run off and haul them out? Don't do that. Not unless you drop a tourniquet or something over there to control return blood flow, because with crush injuries, you have massive release of cytokines, and that'll start this whole ball of wax. Ischemia, microbial invasion, infection, endotoxin release, secondary to infection, and perfusion deficit, secondary to everything else going to pot. All right, and that is pretty much the core of it. I'm going to give you one more slide, two more slides here. I want a quick review about ARDS. I don't know how much you had for over the last few weeks, but I just want to remind you that ARDS is acute respiratory distress syndrome, severe inflammatory lung injury, hallmarks of refractory hypoxemia, dropping in lung compliance, and infiltrates in the lungs. Basically, you're building up fluids in lungs because the alveoli are not getting good perfusion and they're leaking fluid into the alveoli, causing you basically to drown. Mortality increases as ARDS progresses despite support. And if you look at this in an X-ray, it's going to look like your lungs are pasted in white. Clinical signs: dyspnea, tachypnea, and hypoxemia unresponsive to oxygen because oxygen cannot get to the microvessels, the capillaries in the lungs. If you're not oxygen is not getting to the lungs, you're not getting exchange, it's not going to do you any good. Bilateral infiltrates on chest imaging, atmospheric oxygen FiO2 ratios are going to be around 200 as your diagnostic marker, and progression will lead to mechanical ventilation. With mechanical ventilation, we're looking at ARDS and MODS respiratory failure. Generally, our strategy is low tidal volume, high PEEP to prevent alveolar collapse, monitor for ventilator-associated pneumonia, VAP, and sedation, because if you're trying to breathe if you're trying to inhale while the machines are making you exhale, or you're trying to exhale while the machine's trying to force you to inhale, generally you're going to be out of synchrony and you're going to have a whole lot of trauma to the patient. So a lot of times we will put that patient into a light sedation or more, depending on the situation. Propofol will be your best friend. Propofol. Let's see. Chest tubes. Now, I know this is cart after the horse because you already took the damn test, but chest tubes is there to manage pneumothorax, and pleural effusions, ensure the patency, monitor drainage, and maintain sterile technique. This, again, should have been part of the lecture you had a while back. It's just a quick view so that when you understand when we're talking about organ failures, you know why this is happening. All right, that's about all I have for you, except I want you guys to see this. Normal versus ARDS, gas exchange. In a normal patient, the alveoli are open and compliant. You're getting perfusion at the base of the alveoli, and things are going to happen. In ARDS, they're stiff, they're not opening, they're not closing, you're not getting gas exchange, and the gases are not being perfused. So, and bottom line is that with ARDS, the lungs are going to fail. You're going to be essentially drowning. And if we don't manage that, there is not a whole lot we can do about it. But maintain pressure and try to manage the cause of the fluid buildup and the trauma stress trigger. So other than that, once I get the everything done this week, hopefully week 9 and week 10, we can follow along on our regular trajectory. And if I will be able to have your class and my class on the same time with the same link, doing the same thing, which would be a very novel idea, but we're going to get there. Hope you guys are having a good day. Take care. Have a good Thanksgiving.